Good morning, everybody, and thank you for coming along to the first session of the final day of the conference here in Liverpool. My name's Jonathan Ellis. I'm Director of Advocacy and Change at Hospice UK, and I'm going to be chairing this session. My role, as well as being about advocating with government and decision makers, the other part of my role, which is perhaps more exciting, even more exciting, I should say, is the change component. And this is about trying to find new ways of working, new ways of tackling some of those challenging problems we're facing in palliative and end-of-life care around changing demographics, new demand, growing demand, unmet need, and of course taking population health approaches to meeting the needs that exist within our community, new ways of working, making a reality of that rhetoric around integration, collaboration that is so commonplace in the health and care system this morning. So I'm really pleased to be chairing this session because I think we're going to get a really good live example of how we can translate that rhetoric into action. So this session is we've got three speakers who I'll introduce in just a second, showcasing some work that St Helena Hospice have been doing with the Oxford Centre for Triple Value Healthcare and Imperial College London to create a triple value population healthcare system for end-of-life care in North East Essex. And triple value is all about value to the individual, the technical value, and value for the whole system. So I think we're in for a really interesting presentation this morning. Our three speakers on the panel today, we have Mark Jarman-Howe, who's Chief Executive of St Helena Hospice, Dr. Karen Chumley, who's Clinical Director and Deputy Chief Executive at the Hospice, and Dr. Tim Wilson, who's Managing Director of the Oxford Centre for Triple Value Healthcare. So I'm going to hand over to Mark to kick us off.
A very good morning to everybody, and thank you very much to Hospice UK for the opportunity to share the population approach to end-of-life care that we've designed and developed in North East Essex. I think it's really clear from the content of the conference so far and from the conversations that I've been having with colleagues in the margins and over coffee and at the bar that a lot of hospices are quite preoccupied at the moment with concerns about protecting current service delivery, let alone feeling that they have the resources or the headspace to think about unmet need, tackling inequity and coping with the rising demand that we see for end-of-life care and hospice services. And it certainly is a difficult time at the moment. But I also think that there are some unprecedented opportunities for hospices to think differently, to be bold, to be radical, and actually to achieve some much better outcomes for end-of-life care for the populations that we serve. The key starting point for that, I think, is being brave enough to put aside our hospice interests and to start with the proposition of what's important to dying people and their families in the local area, in the population that we serve, and to have faith that if we focus on that and work with other stakeholders in the health and care system on what's best for end-of-life care, that actually from that a clear role and opportunity for the hospice within that will emerge. What we're going to be talking to you today is outlining the methodology and the approach that we're taking in North East Essex. It's very much a live case study and a work in progress, but we're very clear that we're on a journey and we're confident that we're going to have a positive destination. And we're really hoping that colleagues who have the vision, who have the resilience and have the risk appetite will work with us and talk to us because we'd love to collaborate with others in further developing this model. The policy, the commissioning, the operating environment for health and care is changing rapidly at the moment. The NHS Long Term Plan sets out a very clear direction of travel. The key shift, I think, is away from what we've seen over the last couple of decades, which is a focus on competition, procurement and choice as drivers of improved efficiency and performance, toward a focus on collaboration, integration and co-production, where the focus is on improving health and wellbeing outcomes. And whilst the long-term plan, I think, is a missed opportunity to set out a really clear and decisive vision for end-of-life care in England, it nonetheless has a number of hooks that we can build on to develop a compelling end-of-life care proposition. And in many respects, end-of-life care is the perfect programme of work to apply integrated care principles to. Increasingly, that long-term plan is not going to be dictated to areas and local systems from the top. It's going to be sustainability and transformation partnerships, STPs, and integrated care systems, ICSs. They are going to be the footprints within which the key decisions, the key priorities, and the decisions about where resources are going to be allocated are going to be happening. And there is a narrow window of opportunity at the moment that if you're not already engaged with the governance and the operating structures within your SDP or your ICS, you need to do so urgently because all of those SDPs and ICSs are currently working on finalising their 5-year system strategic plans, which is setting out explicitly how they are going to deliver the long-term plan priorities for their given population. And you really need to make sure that end-of-life care is a clear priority within that plan. Otherwise, you're going to find it very hard to be successful amongst so many competing priorities over the next few years. Within Suffolk and North East Essex, which is the system of which we're part, thanks to proactive working from ourselves and particularly colleagues in the adult hospices in Suffolk, not only have we got end-of-life care as one of the key higher ambitions for our system, we've got a very clear section within the draft plan that sets out our priorities and our plan for end-of-life care. And we've also got, in addition, separately, a section on the important role that hospices play as stakeholders within the health and care system. For those of you that might not be so familiar, SDPs were sort of launched in April 2016. They're a way of organising England into discrete geographic areas and asking NHS organisations and local authorities to collaborate together across traditional boundaries to improve health and wellbeing outcomes for their population. There are 42 areas across the country. 14 of those SDPs have now had an acronym upgrade and are now ICSs. The key difference between SDP and an ICS is a mature form of collaboration where certain milestones have been achieved and where there's greater opportunity for earned autonomy, a degree of freedom from interference from health and care regulators, more opportunity for local determination of priorities and ways of working, and really an opportunity to engage with the local area, the local population and stakeholders to design and develop more integrated approaches to care. Within each of those systems, we're starting to see 3 key tiers at which things are going to be organised and at which decisions are going to be made at the future. And I would strongly advocate that all of us as hospices, again, if we've not done so already, should be thinking really carefully about how we engage and influence at each of those levels. The exact structures will look slightly different from system to system, but broadly speaking, you have a whole population level, system level, where in our case, the population is 1 million in total. So it's really important that hospices are collaborating together with other end-of-life care stakeholders to influence a compelling high-level set of priorities and plans for end-of-life care for that whole population. I think a lot of the really interesting work and decision-making is going to happen at the place or locality level. In our case, North East Essex is a collaborative footprint of 350,000 population. So most sort of medium to larger size hospices would have a catchment area broadly fitting with a place-based level. For us, we're lucky. Our geography and our catchment as a hospice is pretty much entirely coterminous with our place-based collaborative footprint. For colleagues that have a crossover of systems, I appreciate it's much harder, and if you have an overlap with other hospices, then it's going to be much harder. But you really need to think carefully about organising yourself around their footprint, not your footprint, because that's where the decisions are going to be made. And then the final level is within neighbourhoods. This is populations of between 30 and 70,000. This is where the really interesting stuff is going to happen in terms of community models of care with greater integration of mental and physical health teams, greater integration of health and social care teams, working together with voluntary services and community assets to support the developing primary care networks. An important technical point to note, though, is that those neighbourhoods will be similar to, but may not be entirely the same as the primary care network populations. So as hospices, you need to think about how you're engaging with the emerging integrated neighbourhood teams in your area, and also how you're influencing and working with primary care networks. Within our integrated care system, we have 3 place-based collaboratives, which we call alliances. Ours is the North East Essex Health and Wellbeing Alliance. It includes all of the NHS organisations serving our area, commissioners and provider trusts. It includes the large social enterprises which deliver a lot of community contracts in our area. It includes all the local authorities, that's the county council, the district and the borough councils. It's got very strong voluntary sector representation, including St Helena. And we've all come together because we believe that by breaking down some of those traditional boundaries, working in an integrated fashion, thinking differently, we can collectively transform the outcomes for our local population. And what we're going to see is ever greater integration, both of delivery of services and the commissioning and the decision-making around those services. I would advocate very strongly that there is an opportunity in these emerging collaboratives for hospices to step up and play a significant system leadership role, but you need to be proactive and put yourself out there to make that happen. St Helena took the decision to get involved for 3 simple reasons. 1, we buy into the vision. We don't just deliver hospice care, we also live and work, and our families live in the area that we serve, so we want better health and wellbeing outcomes generally as well. We want to make sure that end-of-life care is a priority, and finally, we believe by engaging, it's more likely that our organisation will be sustainable and successful in the long term. To really make sure that that happens, Karen, who's going to be talking in a moment, has taken on the Senior Responsible Officer lead role for end-of-life care for the whole system. She chairs the End-of-Life Clinical Board, which increasingly is where the key decisions are going to be made, and in due course, where resources will be allocated as well. And she's also representing our system on the Integrated Care System End-of-Life Board. And we've taken that a step further. I'm currently seconded half-time as executive lead and chair of the Health and Wellbeing Alliance. So I'm actually heading up and leading the whole span of work across health and care in North East Essex that covers the whole life course for everybody living in that area. And that's really giving us a unique opportunity to create a sympathetic environment for the sorts of priorities, ethos and way of working that we want to see in our area. We've been able to sort of put ourselves in positions of influence because we've worked hard at this for several years now, and there have been a number of iterations along the way about different forms of collaborative approaches to end-of-life care. Starting back in 2013, we co-funded the development of a palliative care coordination centre and an end-of-life care register, which we call My Care Choices in North East Essex. That gave us the opportunity to take a lead in the delivery of those initiatives, working very closely with a number of other health and care partners. There was a big risk in us doing that operationally, reputationally, and certainly financially. We committed about £1.4 million from our reserves over 3 years to make that happen. Plus, we also needed to significantly increase our recurrent fundraising to cope with the additional costs that we were incurring. But the trade-off was we secured a £1 million uplift in our grant baseline, which we've continued and built upon in the several years since. Building on that success, we negotiated the first ever joint commissioning agreement with our CCG, which meant that we were actually influencing the outcome measures and the priorities for the whole system, not just for the hospice, and we took on a lead provider role at the time. So we were commissioning as a hospice directly with primary care services. We were managing grants to other charities, including the Marie Curie service, and to other hospices locally. From there, when SDP started to be talked about, the initial terminology was about accountable care systems and organisations rather than integrated care, which is what we have now. We took the opportunity at the first meeting, more or less, to propose that end-of-life care should be the area where we prioritise testing those accountable care principles within our system. From there, we've managed to get buy-in to an integrated vision of what end-of-life care should look like for our population, and an agreement that we should be working towards system success measures, not individual organisational KPIs. And from there, we've created the end-of-life board. And now, the next stage, which we're really excited to share with you today, is we have influenced the whole Live Well model described by the tree behind me, which covers the whole life course from start well through to die well, and using that framework, we are populating the die well with a really innovative population-based approach to end-of-life care. And I'm now going to hand over to Karen and Tim, who are going to talk you through the detail of that methodology.
Thanks. Thank you. Thanks, Mark. So it's my job to translate this management language, I think, into something that I, as a clinician, can understand. So my name's Karen, I'm a GP, and I'm the clinical director of St Helena. And I want to really just start thinking about this subject by sharing a patient's story. I want to talk about John. John was born in 1928, when John was the same age as my youngest son. The war broke out. I can only imagine his mother's relief when the war finished just before John was called up. When John became an adult, he married a woman that was much older than him, and they were not destined to have children, but they were destined to have a very long life together, a very long marriage. In fact, their marriage lasted well into John's 90s and until his wife was nearly 100. In 2005, their memories began to fade at the same time, and they were unable to live independently. Eventually, they moved into a residential home, and gradually their dementia became more severe. They were unable to converse with each other, and they sat side by side in their residential home. In February 2019, John developed sepsis. This was brought to the attention of a visiting GP who was seeing another patient and was asked if she wouldn't mind having a look, just a quick look at John. John was very unwell. He had a potentially reversible condition. He had no plans in place. There was no advanced care plan, no lasting power of attorney. He had no living relatives that could answer for him and make a best interest decision. Nobody had really reflected on the quality of his life and had any advanced thoughts or plans as to what would be best for John if he became septic. This GP had never, ever met either John or his wife before. And in that situation, with no notes and no history, had to make a decision about whether it was the right decision to treat his sepsis. And I think it's understandable that in that position, that GP chose to treat John's sepsis and admit him to hospital, with the view that if he recovered, that those plans would then be put in place, with a time of reflection, gathering the thoughts and the opinions of those around him. But John went to hospital. He spent a prolonged period of time in A&E, and he died the next day in the medical assessment unit, on his own, away from everybody that knew him, with nothing of the story of his long life, his long and successful marriage around him. And my question really, when I think about population health, population end-of-life care, is who is my patient? As a clinician in the hospice, is John my patient? Or are my patients just the people who are receiving hospice care? And I think that this population management approach really relies on us perceiving ourselves as leaders of care across our whole community, perceiving that John is also my patient, even as I concentrate my clinical care within the hospice. So as hospice doctors, as hospice nurses and clinicians, are we providers? Are we leaders? I like to think that we are leaders. We are people that see what good end-of-life care looks like. We see how meaningful it is, how beautiful it can be. And we should be the advocates and the agitators for that care across our community. In North East Essex, the hospice sits in Colchester, and on the coast, we have an area of great deprivation and a large number of care homes. It is as much my business, the quality of the end-of-life care for the people in those care homes who are never referred to hospice services, as it is today for the people that are in hospice beds this morning. I wanted to talk just a little bit more about the role of the My Care Choices Register and the work that we've done. We've been involved with My Care Choices now for 6 years, and we have recently done a big promotion of the My Care Choices Register, the EPACs, straight to our population. One of my colleagues here, Sally, organised a big campaign. It was funded through our Alliance End of Life Board, where we embrace this register not as a tool for hospice patients or cancer patients, but as a tool for our whole population of people approaching the end of life. We advertised it directly in the media, on social media, on the back of buses, bus tickets, petrol stations, encouraging the conversation across our society so that people were starting to have these conversations and approaching their GPs rather than doing it entirely through the health system. And I think that's given us a really good building block for the work that we're doing. Now we know that about 40% of people who die this year in North East Essex will have had an opportunity to record their choices for the future. And what we've done over the last couple of years is widen the register so that people can record their choices even if they're not in the last year of life. So people like John can record their choices for their future care much earlier, before or early in their diagnosis of dementia, so that later on, when they don't have capacity, those decisions can be reflected upon. And what that register has enabled us to do is start looking at what happens. What are the outcomes for people that are on that register? And we can see that if somebody has an entry on My Care Choices, that their chance of dying in hospital is very small. It's 20%. Our local average is 46%. That makes me think that being on My Care Choices and having these conversations really is a powerful intervention. It changes the way we work together as a community of providers. We have spent a lot of time, and it's been a real challenge to get My Care Choices linked with all the clinical systems throughout North East Essex. The paramedic service, GPs can access it, the hospital. We've done a lot of work encouraging the hospital to look at it. So now, every day, on the wards of our local hospital, the nurse in charge will get an email to say who on the ward that day of her patients is on My Care Choices. And they measure how many people have their entry looked at while they're in hospital. We can see what percentage of people on My Care Choices achieve their preferred place of care. I can confidently say that I know that our population doesn't want to be cared for in hospital at the end of their life because I can see what their choices are. Only 6% of people on My Care Choices say that they would like to be in hospital towards the end of their life. And I think it's meaningful, therefore, that we support them to be cared for where they want to. That's not purely about economics. That is about delivering something that we can see as a priority to them. And so we've had some success, but we haven't arrived. We have reduced the number of people, the percentage of people that are dying in hospital in our area, and that's been faster than the decline across the country. If you can see here that in comparison to similar CCGs, we do quite well. We're not the best, but we have had some improvement. However, I think sometimes we're like a salmon sort of swimming up a fast-flowing stream. We're swimming against the tide of over-medicalisation of our population at the end of life, particularly our oldest old. And despite the fact that people are not dying in such a large proportion in hospital, we are seeing an increase, a 44% increase in the percentage of people that have 3 unplanned admissions at the end of life. Again, we're not doing bad compared to comparative CCGs, but this is work that is important and that we haven't achieved fully. So, this is how far we'd got about a year ago. We were pleased with our success, but not resting on our laurels. We could see there was much to do. We could see that the tide of medicalisation was against us. And we read this article by Kerry Thomas and Muir Gray that was in the British Journal of General Practice. And it's about population health. And I think probably when you look at this, you think, we're doing this. We're doing population health. We hadn't called it population health. It wasn't a term that had become so fashionable at that stage. But this is what we're doing. We're looking at our population. We are working with primary care. There was a locally enhanced service for GPs to recognise people in the last year of life and to recommend my care choices for them and to encourage them to support their patients to achieve their preferences. What we were doing was population health. And so we looked at what population health had to offer us because we wanted to take the learning that we had and the successes that we had, and we wanted better outcomes for more of our population. So that's when we started working with the Oxford Centre for Triple Value Healthcare, or 3V, and we took their approach to population management, and we have used it to develop our thinking and our work further. What I've learned is that population health management is the new black, isn't it, for NHS? It is the new way. Everybody's talking about how they want healthcare to run. And I think what I'm here to say really is that if we can see the resonance between the work that we do and population health management, then that will give us some power and authority to say, hang on, this is what we do. This is what we do well. And if you invest in us, we can deliver better things for people at better value. John had really poor value care. He died in the most expensive medical environment that our community offers. And yet that was potentially not a good place for John to be. So we need to be thinking, well, how do we get better value? How do we look after people in the place that they want to be or receiving the kind of care that they want, and not waste money paying for healthcare that people don't want? So this is my list of how I understand population health. What I've learned is that if you Google it to really clarify the definition of population health management, there isn't one, there are many of them. So this is how I understand a population health approach. That you think about who your population are. That you clarify what is the most important thing to that population around the condition that you're dealing with. And then you measure it. You measure what you're achieving, not for your individual provider population, but your whole population across your area. And then you create your case for change. You look at it and you say, how can we do this better? It's my privilege to chair the End of Life Board locally. And so I sit around the board with people representing care homes, charities, community health providers, mental health services, the hospital, primary care, and we put our heads together and say, how can we do this better? This is all our responsibility. The next step was creating a network. Well, we're very fortunate that network through the Alliance already exists. There's an important role of engaging patients, and I'll talk a little bit about that in a moment. You work out what your budget is. I think of this as that we all have our little bag of gold under the table, our budgets, and this is the equivalent of us all reaching under the table and putting our bag of gold on the table and saying, let's spend this better together. If we're going to do that, we need to have some authority delegated to us. And that is a work in progress as alliances develop and the commissioning structures change. But mostly, I think this is about us looking differently at our culture, daring to put our budgets on the table, daring to not be too protective over them, but take responsibility all together for sharing the outcomes, the responsibility for the outcomes for our patients. So, what does this mean for end-of-life care? Well, we are defining our population. You could define it in many ways, and I don't think there is one right answer. But for us, we've decided to define it as the last year of life. And within the people in the last year of life in North East Essex at the moment, there are people who receive really good, high-value care. We see them. That's our hospice business. People who are cared for with support of community hospice services, supported in their own home to die with good symptom control. That's already happening. That is a subgroup in the population that we're thinking about. But also within our population, we have people that are receiving poor quality care, people like John, people receiving expensive care that is inappropriate, and we can spend differently to get them better care. And then there are people in the last year of life that we are unable to plan for, people who have sudden deaths. And we do need to acknowledge that of all the people that are in the last year of life, there are some people for whom palliative care and end-of-life care would not be appropriate. Then we need to clarify what is important for the population and how and exactly what the focus of our work is going to be. So we have clarified it with this statement. We want to improve outcomes that matter with the resources that we have across our community to increase the value of care for adults in the last 12 months of life. I think it's really important to be really specific about who we're talking about, what our responsibility is, and where that is boundaried. What we did is we did a bit of engagement with staff, frontline staff, and patients and their representatives. And it was a big piece of consultation where we looked at what was important to that group. I can't stress enough how important it is to do this. So I stand with the authorities. I know what is important to the people at end of life because they have told us. And I'm going to focus on just 3 of the outcomes that they said were the most important. I put this slide in so that it's there if you're interested in a copy of the slide, so you can see what our population said were the 10 most important things. So I'm going to just focus on 3 of them. They said that they wanted to be identified. They wanted to know that they were approaching the end of life. They wanted to have honest conversations. And so we want to think, well, how are we doing? How are we achieving that across our community? And so we want to measure. But we have a measure already in place because we can use the My Care Choices register for that. Because if somebody has had that conversation and they're on the register, then we know there has been an element of identification. They have to consent to go on the register. So we can measure the reach of that. People told us that they wanted to minimise inappropriate medical intervention. So what we can look at is hospital admission data, and we can see, well, across our area with our central hospital, what's happening? How often are they going into hospital? How many of them are being cared for right at the end of life in hospital? But also, not just the last days, but in the last year of life. What is our hospital use? And can we use that resource better for the population we serve? They also said that they wanted their preferences to be respected. And so a marker of that, an indicator of that, is the achievement of their preferred place of care at the end of life. So we can measure that and take shared responsibility across our whole area for what proportion of our population achieve that. So we have got to this stage, and what we have created, what we are working to create, is something called an atlas of value. Many of you will be familiar with the atlases of variation that enable us to compare the achievements in key markers with other areas. And what we're creating in our area is an atlas of value, where we take the outcomes that matter to our population and we look at them and we examine how much we're achieving, and then we look at where our spend is, and then we question ourselves in some detail about how we can do that better. And I'm going to hand over to Tim now to explain a little bit more about that piece of work.
Thank you, Karen. I think this might be the first time ever I'm going to be heckled by a dog. Anyway, so maybe that's a fair commentary on what I'm about to say. It was sort of, it's funny, isn't it, how you sort of hook up with like-minded people. I mean, the NHS employs 1.4 million people, and it's said that you actually know all of them some way or another. But we got this phone call, when I say we, the work we do at the Oxford Centre for Triple Valley Healthcare, we're a tiny, tiny social enterprise. We were founded by Professor Sir Muir Gray. Some of you may know his work, but Muir has been working at population health for 35 years. His first paper was in the Lancet, 36 years actually. His first paper was in the Lancet in 1983. So it's a bit of an overnight success, his work. And we got this phone call from this strange gentleman called Mark Jarman Howe, and he said, I'm very interested in what you're doing. And it was very exciting because here was this person across in Colchester who was talking our language. It was so refreshing. And then we came and visited them, and these were people really thinking differently. And so it was very exciting for us, this thing, because when we go around the country, we're very, very privileged to work in lots of different places. Pretty much every provider, and I suspect this includes hospices, pretty much every provider is in an incredibly transactional place. They're thinking, oh, how can I get more money out of the CCG? And CCGs have driven that. You know, I used to be a GP, and that's where GPs are. You know, every time they want, you know, it's always, well, how much are you going to give me for that? And here was a hospice who decided, no, we got to change the paradigm here. We got to be on the front foot. We have a really important and valuable service to do. We have a service to the whole population. We met a medical director whose question was, who is my patient, which Karen's just described to you. So the Atlas of Value, which we sort of started work with them, and it's still in progress. This is quite hard stuff to do. Builds on the Atlas of Variation that many of you have seen came out in November last year. And it's fundamentally a tool for change. If you remember culture at the bottom of Karen's thing, these atlases are not about precision, and we try and be precise as possible. They're really fundamentally about people realising they're going to have to do something differently, because what they're presently doing is not using resources in the right way. You know, as a whole, this is not about finger pointing, but as a whole, we collectively need to start using resources differently. And that includes hospice resources. As Karen said, it's about people thinking, actually, no, this is right. I'm going to reach under the table, get my bag of gold and put it onto the table because we have something to contribute. And so it's the start of something. So it's a way of starting to change things. And I'm going to give you some of the results. Some of the questions are unanswerable. You know, we don't know what is right in some cases. But the point is, it poses other questions. We talk about this idea of a mix of curiosity and discomfort. We want people to be slightly uncomfortable with what they see, but also curious. And so then they engage with it. And there's two phases to the Atlas. So the first phase, which you're going to see some results from in a second, is just using the data we've got. But again, just to pick up on Karen's point, there is this movement called population health management around the country. We at 3V have stopped using the phrase too directly, but because I guarantee, I don't know how many in this room, 60, let's say 50, I guarantee we would say to you, well, if you had a definition for population health management, so a lot of people just scratch their head, but if you have one, I guarantee there'll be 50 plus one. I mean, it's become one of those terms, a bit like integrated care 10 years ago, where everybody had their own thoughts and meaning, what it actually meant. It's quite a difficult phrase. However, the point is there's a big movement going on, and there are resources happening, and you can start start to tap into that, and that's what we're doing. So the second phase is where we're going to start to tap into that PHM, population health management movement, and all the work that's going on, the money that's come from Skipton House and NHS England, to actually link data sets. So the second phase is we'll have linked data, hospital data, GP data, My Care Choices data, and hopefully eventually the hospice electronic health record, and then, and on and on. So basically we will have one database we can start looking, and we can see really what happens to individuals and what the impact is on their care when we apply resources in a particular way. But I'm going to give you some stuff from the first phase. You reckon, those of you who looked at the atlas of variation that Public Health England produced, you'll know this, and I apologise. I think the theme of this conference, you've already discussed the fact more people will be dying. So, if we don't start today thinking about how we can give people a better, higher quality, higher value end of life, if we don't start today, we've got a problem. Because that trajectory you saw of the rising 3 or more emergency admissions, and it was there's the 44% over the last 10 years increase in 3 or more emergency admissions. That's going to get worse. We are medical intensity increases every year, and that's going to get more and more and more. So if we don't do something now to really address this, we will be failing that population, Karen's patients, who is everybody, not just the folks in the hospice. And of course, people are dying of different things. You know this. I apologise for telling you what you know. People are not dying of stroke anymore, it would appear, but they are dying of dementia. So it's the nature of what people are dying of is different, and that makes life very different. This just give you a rough scale. When people start to bring their, actually put those little bags of gold on the table, this is where actually, I'm going to paraphrase Mark here. Ask not what you want from your CCG, but ask what you can do for the people at the end of life. When you ask that question, then actually he's paraphrasing Kennedy as well, isn't it? But when you ask that question, suddenly the pots of gold that put on that table suddenly reveal themselves. And the point is, of course, look at the scale of what's happening in the last year of life. None of you will be surprised at this, but that big blue blob or slice of pie, which would leave you feeling rather overfull and give you a bit of heartburn if you ate that much pie, but that big blue bit, that is those 3+ emergency admissions. That is people being medicalised. Now, some of this is good stuff. Some of this is really great care people are getting. So we're not talking about this is all bad, but some of it, from what we heard from the people we spoke with, the families, the patients and others, what we heard, some of that, they really don't want to happen. So there's a big amount of resources going there to over-medicalise people. That's a problem we have. And then you obviously look, the orange one is just to remind you what the benefit, the charitable benefits that are coming into the NHS are almost always forgotten. Now, there's missing bits in this slide, and I'll come back to them particularly around things like primary care, which is very hard to get cost data around. But this gives you an idea of this scale. Now, this is where it starts to get really interesting, where the primary care bit comes in. So, on this graph are sort of 3 different groups: high, medium, and low user. And this means high, medium, and low users of My Care Choices register. And it's practices. So we're now talking about practice characteristics. There are 3 different types of practices, the way we've categorised them here. Some use it My Care Choices a lot, some use it less so. But look what happens. If you are lucky enough to be registered, you need to check, by the way, these are our friends, other friends from Colchester. You need to check, if you're registered in one of those high care, high user practices, you're much less likely to die in hospital. Statistically so. This is a statistical significance. So this is the power of that £1.5 million investment, but it's also the power of proactive care. It starts to show, if we actually do proactive care, do you know what? You're much less likely to die in hospital. And, we talk about complexity and people with comorbidities and all these people dying of different things nowadays. it's even more interesting when you start to look at, and it's very difficult in those kind of circumstances, or more interesting when you look at people with 3+ medical conditions. Because if you're one of a medium or low users, you're more likely to die in hospital if you've got comorbidities, whereas the benefits seem to be sustained if you're in one of the high user practices. And the point is, if we can start to somehow release some of the resources from that big blue pie slice and start to invest in primary care networks or general practice by helping support them, we can start to see these benefits accrue right across the system. And it's actually not a lot to move, actually. It's not a big shift. We're not asking them to do a whole lot. And some of the approaches that have been used by practices in culture that are having this dramatic effect are quite straightforward. It's not a GP going out every time. Sometimes it's healthcare assistants and others. So there's lots of very smart things that practices and PCNs can learn from each other. But this is what the End-of-Life Care Board can do as it starts to think, OK, let's see, we've got these bands of gold. How can we start to move them around? And this is what the Alliance is doing. And, for those of you who like a bit of sexy statistics, here it is. This is just basically what this is showing. There is a statistical correlation between My Care Choices use and spend on patients in their last year of life. If you are good at... it's sort of common sense, isn't it? But isn't it nice to have it really shown, statistically proven, if you're good at proactive, planning ahead, thinking about preferences, talking to patients, you're going to spend less at the end of life. But you know what? What's even more important? They're much more likely to have better outcomes. Isn't that terrific? We're spending less and you're getting better outcomes for that whole population. This is what hospices can do. We try to calculate roughly what are the what kind of resources could we start to shift around if everybody moved. We don't talk about savings. That's quite an important bit. We're not talking about money that goes into some amorphous pot. We often say that savings equals BHI. Do you know what BHI means? Black hole of incompetence. So when you hear savings, you think, well, that's just going because somebody's incompetent somewhere else. No, we talk about, look, these are resources going to be taken out of one, that pot of gold and put in this one because actually we want to do better things for people at the end of life and get better outcomes. And that's part of the thing. We're going to start to manage the resources. That's the authority. And depending how we calculate it, if we get all practices up to the higher MCCR rate, there's around 700,000, based on an audit that was done before we arrived by St Helena and colleagues, it could be almost as high as £1.2 million of resources we could reuse. Now, this is just the resources. You've then got to spend it elsewhere. So that's why you don't want to think of it as savings, because we're going to have to reinvest it. This is not some net gain. This is something that can do more good. So we'll wrap up now. Hopefully you've got a bit of time for questions. For the more managerially inclined, although we're always slightly wary of making that distinction between managers and clinicians, because clinicians do manage. But anyway, this is sort of what we're doing with St Helena and more appropriately the Health and Wellbeing Alliance, and then the ICS, because it's an ICS priority, it's for them. So this has got the spotlight of the ICS. This is where we are. We've done these 3 bits here. You've heard some of the results from Karen and from me, and then we get into sort of some crunchy stuff. How is the end of life board going to be held accountable? What's the governance framework for the end of life care board? How will they monitor and evaluate to show success? We would argue, what will the annual population report look like, which is published in the Colchester Gazette or whatever it is, the Tring Chronicle, I think, not Tring, Tendring Chronicle or whatever, or News. What are the rules of delegation of authority? This is not straight sword stuff, moving stuff around systems. We're talking about hospital beds, we're talking about all sorts of things. Some things are easier to move, like variable costs, like pharmaceuticals and so on. Some things are harder to move, workforce, beds. How is the money going to flow? And more importantly, we need to design a training and support program for the end-of-life care board. We're going to ask them to do things they've previously done bits of, but we're going to ask them to take more and more duty on it. We can't just leave them stranded. And then finally, that needs writing up in some sort of contractual vehicle. So that's really where we're going. Karen, do you want to finally wrap up? Oh, sorry, I beg your pardon. I was going to just say this one final thing. This is just one way of visualising what we're trying to do and trying to encapsulate what Mark was describing at the beginning. At the moment, we all work in hierarchies, and we could have had on that left-hand side there a hospice. You know, we have lots of hierarchies in the health system that all work quite separately, and they don't really. I mean, those hierarchies doesn't work neatly, does it? So what we're trying to do is, and those hierarchies are very important, by the way, because they employ people, they build beds, they get scanners, they do all sorts. You know, there's really important things. We're not talking about the complete abolition of those hierarchies. And by the way, if you're trying to merge those hierarchies, it'll take years and it'll be distracting and you'll do nothing. So what we're trying to do is build on what with St Helena is build on what they'd already done. They already had this network of the End of Life Care Board, and we're gradually trying to build that. So I'm going to just tell one more story, I'll be really quick. As we were walking in, so a lot of this work we're talking about today is actually based on quite profound economic theory. In 2008, Elinor Ostrom was the first woman to get the Nobel Prize for Economics. And she went round the world and she realised that if you had a group of people working together in a room, collaborating, they could use resources more wisely than some higher authority. Chris Ham's just written a blog about this, interestingly, if any of you read the Health Service Journal. And she realised that. And what happened is people set their own rules, they define their, but they were much better at using resources. It won't surprise many of you who work on the front line. You know, you can probably know how you should be spending money better. And one of the things they did was, when these groups got together, they would set rules. And if someone broke the rule, they had a very quick method of sort of bringing that person back into line. Because these things happen, people break rules. And they had a very quick method. As I was walking in, Karen was just telling me about somebody where she'd had to solve a problem because somebody hadn't done something last night, I think. And there we were seeing Nobel Prize-winning economic work already in action in the End of Life Care Board in the Alliance. So this network was already there. So it's great for us to come and arrive and meet these folks who are already doing things. And all we're doing is just building on that. We're just building this network. But we saw Nobel Prize-winning economic theory in action. So that's what's happening.
So, I think it's my job just to close, and I think I just wanted to concentrate on why. I think we are so privileged that everything that we do in hospice work is really meaningful, and I think this gives us the opportunity to do something very meaningful across our whole population, across our whole community. My father has early dementia, and I want to live in a community where his end-of-life planning is prioritised as highly as a patient of mine with cancer. I want to live in that sort of community where I'm working in collaboration with charities that will support my family in a much broader way than hospices could ever offer. I think I want to concentrate on the yes, we can do this. And this empowers the hospice agenda further. Instead of taking away and disempowering us at a time of financial challenge, this work enables us to be right in the centre of setting standard, of driving, if you like, a crusade for better care that we can confidently say is in line with what our population wants. I wanted just to close with a short video. It just lasts 3 minutes of one of our hospice ambassadors who talks movingly about the death of his wife. And I want you, just as you watch it, just to contrast it with the run-up to the end of John's life and the quality of the care and the planning for somebody like John. There are thousands of people like John in our community. and not just those with dementia, those with COPD and heart failure, whose plans are just as important as those who have cancer and have more traditionally received hospice services. And so I want to finish with a so what. What are we doing? Why are we doing it? And I wanted to leave the last words to Chris, one of our ambassadors.
When you're first told someone you love is dying, when they're first told, it's a terrible time, it really is. There are so many things to think about and worry about, and you need to talk about them, there's no other way. When Val was told she was dying, one of the things I knew that were worrying her, she wanted to die ideally at home or in the hospice. And I know this preyed on her mind. And our GP, Dr. Chumley, came and she introduced us to the My Care Choices register. And this was great because it meant that Val's wishes had been listened to. She knew they were written down and that somebody would pay attention to them. And if at all possible, she could die at home. As soon as we did it, we had a visit from the occupational health people who came and checked that the house was suitable. Obviously, if you want to die at home, there has to be space for a hospital bed and other facilities, which we had. From experience, I know it worked, and it worked well. Towards the end, Val was deteriorating. The medicines to relieve her symptoms weren't working. She couldn't get into the hospice, there wasn't a bed available, so they took her into the general. The specialist came round and told us what we already knew, that the medication wasn't working. And he said, we have one more shot in the locker. If that doesn't work, there's nothing more we can do. We just have to let nature take its course. And then he said, I see from your notes you want to die at home. If the treatment doesn't work, then we will arrange that. And the effect of that was amazing. It was like pulling the plug out of a bath. The stress and worry just seemed to drain out of her. It was quite remarkable. As it happened, the treatment worked and we had several more wonderful months together. And in the end, thanks to the My Care Choices register and Single Point and a raft of other services Essex cares, Val died in the house she loved. The support we had was phenomenal. People and equipment just seemed to appear out the woodwork unasked and made my life so much easier. In the end, Val died how she wanted. In the house we'd lived in for 30 years, surrounded by all the memorabilia of a very busy, happy life. She died in my arms. I had time to kiss her one last time, tell her I loved her one last time. She gave a huge sigh and went. In part, we were able to do that to a very important part because of the My Care Choices register. If you're faced in the situation we were in, two things. Talk about it, talk to each other, and talk to the hospice, to your GP about the My Care Choices register. It works, it can work for you.
Just a couple of weeks ago, I went to Chris's funeral. It was a great privilege to be there. Chris knew that he was dying. He also recorded his choices on My Care Choices, and he died in the same house, supported by his family and our community services. This is change that we can make. We can empower people in our community to have a better end to their lives, not just within hospices, but across our community. And I'd just like to invite you to work with us, come and see us, and talk to us about how this work can be taken into other areas. Thank you very much.
Thank you all for a really interesting presentation. I was struck by three things, I think, in particular. Mark, when you described end-of-life care as being an exemplar for integration, and I think it really does have the potential to bridge that gap between the rhetoric and the policy intention and all the things we hear politicians and the system talking about integration and transformation. End-of-life care clearly is a perfect testbed for that, to demonstrate the power and the impact. And Karen, your point that that hospices should see themselves as leaders, not providers, with a responsibility for palliative and end-of-life care needs across the whole community, I think was a really important point, and I think increasing numbers of hospices are starting to see themselves in that way. And I was reminded that we know that every year 118,000 people die in the UK with an unmet need for palliative and end-of-life care. And that means, very back of the envelope calculation, that in every STP area there are over 2,700 people dying every year whose needs are not being met. And so that responsibility to change systems and do things differently, I think, is really pressing. And Tim, your point finally on how we move beyond the sort of transactional focus, that it's very easy to get locked into in a complex and transactional health and care system that we currently have, and how we break free of that using evidence, using data, being driven by the evidence of what works and what can actually change people's lives. We have got some time for questions. So who wants to kick off? It's a bit hard to see with all the lights, but if you put your hands up, yeah, just in there. Corner there, thank you. If you could say who you are and where you're from when you ask your question too.
Hello, I'm Tina Nordra. I'm a clinical director in Hospice Care, which is in Devon. And there's a few of us here from Devon, and I'm sure we'll be taking back some of this because it was great to hear about the implementation and where you are in your journey, because I think our integrated care system is just about ready to have this conversation. So this feels really powerful for me. My question really is about your pie chart of where your resources were, where that spend was. I was quite intrigued by that. And I know you said there was a primary care element missing. My question is about informal carers. So we're just working on carer strategy, and I just wondered whether you'd come across or had any considerations around that element, that kind of, for me in my world, invisible element of informal carers who shore up a lot of this and no, they don't ask to be paid, but there is that kind of aspect of thinking about that. So I just wanted to know your thoughts.
I mean, as you'll appreciate, almost impossible to quantify in financial terms. I mean, you could make estimates and so on and so forth, but the trouble is they start to get slightly unrealistic and so forth. And you'll often see from, national carers bodies and so on, these sort of financial estimates. But actually, I think they sort of discredit themselves. The key thing to do, and as we're, as Mark said, this works in train, as we're writing the atlas, the key thing to do is acknowledge these other resources and talk about them openly. So, we in the conversations about when we're talking about resources, say, look, we've quantified these, but there's these other really important resources we need to consider, like carers. And one of the things to do, because fundamentally this is talking about can we use resources better. So one of the considerations, the reason it's very important to talk about them, even if you don't quantify them, to say, actually, we are to invest a bit more in carers, some carer support, and people in this room will be much more expert than I as to what's effective. Maybe that's a better place to invest. But if you don't acknowledge them as a resource in the system now, then you might forget that. So we tend, our practice, and we're doing this collaboratively, but in what we tend to do is not artificially quantify them, but acknowledge them as a resource, and therefore it might be a place you want to invest in, if that makes sense. A lot of this stuff is tactics. There's not a straight answer, and we frankly are learning. We've learned certainly from these folks here. So if you've got a better thought, then we're absolutely open. And genuinely, yes, I'm aware that Devon is one of the most advanced ICSs, probably similar par to Suffolk and North East Essex. So you're probably a very similar point of maturity. But genuinely, we've got leaflets here. You'll be thrilled to hear. The point is, we genuinely want to make this a movement. We think this is something that could happen nationally. So we genuinely want to share this approach nationally. So very interested to link up with Devon, and we could even sort of perhaps start to compare results and share what we're doing, because this is something we should be learning from each other from.
I think although our carers, informal carers, aren't represented on that spend pie chart, we are working as an alliance around developing more support for carers. It was one of the things that they had highlighted in their outcomes. And so one of the pieces of work we're doing is through the alliance is actually being led by Age Concern, but we are working in an alliance way, is recruiting our first set of, we're calling them compassionate companions, but a group of volunteers that are not hospice volunteers or age concern volunteers, but are volunteers that are community volunteers to support our carers. So although they're not on the pie chart now, what we're saying is, look, this is an outcome that matters, so instead of spending the resource here, let's spend the resource differently supporting that. So that works in early phase at the moment.
Thank you. Liz? Just on there. Apology. Sorry, it's on its way.
Nearly there.
I've done a lot getting up. Hi, Liz Searle from Keach Hospice. Really interesting presentation, and we've been tracking the work that you're doing and are trying to do some catch-up similar work. And a lot of the things that you're seeing, we're also seeing through our own MyCare register, so it's quite good to see that we're tracking similar kinds of things, I think. Our local system got some money to look at severely frail, and we're doing some work with them at the moment. We were quite shocked to see the numbers. We've got quite low numbers being referred for our MyCare system from the severely frail group, which clearly, if you're classed as severely frail, you're probably in the last 2 years of life, so they should be on the register. So that's given us something extra to focus on. But my question really, I think if I understood it, was about reducing admissions, but still seeing an increase in stays in hospital, and I think that's what you said, and I was trying to square that, because I'll go back and have a look at our own data.
And so we have seen a decrease in deaths, proportion of deaths in hospital, but an increase in the proportion of people that bounce in and out of hospital. So yes, so a mixture of benefits from advanced care planning, but also the tide of over-medicalisation, really.
And what are your thoughts about that? What do you think is happening, or what do you think needs to change?
I think, as you say, I think it is around looking at the support of those who are living with frailty and multiple comorbidities. We've also done some work outreaching to the frail population, and we have widened the register in order that people with frailty, earlier frailty, can record their choices on it. And I think it will be around having those conversations earlier, and having far more of them, really also looking at our care home population and empowering them as well.
I'll just add a couple of things, if I may. I mean, so absolutely. We work with another area where their program actually initially was frailty, as you've mentioned, but actually they decided to sort of say the population segment they were looking at was older people over 65, largely driven actually because local authorities do not like the phrase frailty. It is not in their language or their parlance. So they talk about over 65s. But then we said, okay, there's over 65, and that was quite exciting because they actually realised there were people over 65 and they could keep them healthy. So that was good, and who were not frail. And then we classified frailty, I think in that particular instance, into 3 categories: mild, moderate, severe. Surprise, surprise. There's good international reasons for, good research reasons for doing that. But actually very quickly, so having just redefined the work of that group to include well, we then realised that the people who were severely frail were exactly as you said, these are end of life. And so we actually very quickly actually handed over that population group and said, look, actually, to the end of life group, you're much better. This is much more appropriate. You deal with them. This is not. We're not into prevention here. We're talking about quality, hardcore quality of life stuff. I mention that because there will be all these parallel pieces of work going across integrated care systems and so on. And sometimes you get this, it's very hard to work out, well, who's working on this and who's working on that. So some of this population definition, being quite precise, is very useful, because suddenly it makes you think about, actually, people who are severely frail, that is end of life, which is your point, and that's the conclusion. So I'm just really echoing your point. And therefore you start to think differently about it. And it means you need to then have that sensitive conversation with somebody, and you need to talk to them about different things. I mean, you don't suddenly turn up and say, oh, by the way, you've just turned severely frail and therefore you're end of life. I mean, that's not what you do. But you do say, look, actually, it appears that things are getting worse. So it changes your approach considerably and makes you think differently about what you do. So, that's just the experience of another area.
If I may, I just wanted to share a little story. I'm just really concerned about our care home population. I go to a lot of talks, and sometimes I hear them referred to as if they're a sort of homogenous group of people who have similar, who are all inevitably right at the end of life. I mean, many of them, statistically, on average, they live a year. But they are a diverse population with different needs and different preferences. And I'm always very cautious or concerned when I hear admission from care home bad, a sign of always bad care. And I don't think that's the case. I saw a gentleman, I was doing a piece of work doing advanced care planning through a care home. And I was ramping up to sort of meet a chap who I was told had early dementia, and I rang his family to plan for that meeting, and his wife said, oh yes, when she heard what I was going to talk about, she went, oh yes, he wouldn't want to be resuscitated, oh no, he wouldn't want to go to hospital. And then I met with him, and in fact, he didn't have dementia, he was deaf. And when he had moved into his care home, his hearing aids had not moved with him. And in fact, he was profoundly unhappily married. And he was delighted to be in a care home where his quality of life had vastly improved. He was not severely frail. His life expectancy was longer than the average of that care home. And he wanted to share with me that he wanted all active management because the quality of his life had improved. He would accept hospital admission and treatment for sepsis. And I think, and then I saw somebody else and they felt really differently, and they had a more advanced condition and they felt differently about their plan. And yet on a Saturday night in A&E, in their pyjamas with a delirium, those men are going to look exactly the same. And we need to protect people from inappropriate kind of paternalistic decision-making that we make in a hurry, saying, well, that's a care home and, well, we shouldn't really be treating their sepsis. I think we have to really find the people and not perceive them as a population. That wasn't your question, Liz, sorry, but it's just, I'm just aware that is a real challenge to me as we have such a large care home population and we're trying to get better outcomes. But we mustn't do a really broad brush stroke and see the frail through one prism. I mixed my metaphors there.
Yes, sorry, we're going to multi-part answer here. So when you're thinking about value or so on and thinking about populations, there is sometimes, this is just to really echo Karen's point, there's two risks. One is you become very utilitarian and you don't think about some of the very difficult decisions that need to be made. And secondly, we just think, they're in this group and therefore, and of course it is absolutely. So we always say to people, the other side of the population value coin is personal value. And in some ways it's, and actually mostly in end of life, the overlap between, well, there's just almost a complete synergy actually between the two. But in the end, it is entirely determined by the individual. And this is why something like My Care Choices, of course, is so incredibly important, and having those sensitive conversations. The thing that we probably need to, well, one of the things we need to invest in most is in training people to have those difficult conversations. But sometimes finding out, oh no, actually I'm rather happy here and I want full treatment, and then hey presto, you've been surprised. But if you don't have the conversation, you won't know. So we have to support people and help them and train them in doing that, and that will be part of one pot of gold into another pot of gold.
Thank you very much. I think we're coming to the end, and I'm sure there are other questions, but I'm sure the panel will be happy if you catch them over coffee and even at the end of the session. I just want to finish by asking, just for a show of hands, in terms of whether you feel connected, engaged, involved, linked in with your local STP, ICS process, just to get a sort of sense check on that? Actually, that's good. Pretty good. That's pretty good. That's more than I was expecting. That's a good sort of half to three quarters of people, I would say. So I hope what you've taken from this morning's session is some ideas and some approaches that you might be able to take back and have some of those conversations, talking to the St Helena team about more about what lessons you might be able to extract from that. Before we thank the panel and move over to coffee break now, I think, I'd just like to remind you all that if you're avidly collecting your exhibitor stamps in the hope of winning glamorous prizes today, you have until 1 p.m. to do that. So do make sure you take the chance that you've got. But before we move off to coffee, can we just thank our panel for a really interesting presentation this morning.